biofilm. Now, this biofilm is again a huge topic by itself. Management of biofilm has again changed the approach of a diabetic foot surgeon towards a diabetic foot. Now, with this basic medical thing, that is management of sugars, management of gait, management of antibiotics, there are other things which has again changed a diabetic foot approach. The first is involvement of multidisciplinary approaches. That means people from different faculties are now working on towards the treatment of diabetic foot. The first is the plastic surgeons. Today, in a diabetic foot, I can debride to my heart's content without really worrying about the closure of defects. Whatsoever or howsoever large a defect, it can be effectively controlled. If not by just a skin graft, there are things from composite flaps to free flaps, and almost any defect is covered. So essentially, I'm talking of being radical in debridement, which again has made a huge difference to diabetic foot. The second is a vascular correction. When we were students, it was taught to us that diabetes is a microvascular disease, meaning thereby it's the small blood vessels which are affected. The whole concept has changed now. We are now talking of diabetes as not only a microvascular disease, but also a macrovascular disease. So what has it done? Because it's a macrovascular disease, if there are compromised blood vessels, if there is stenosis, if there is an obstruction in the larger blood vessels, I can get a vascular surgeon or an interventional radiologist to correct that. Having corrected the major vessel, it's only because of what they call a pressure head. That means because of a high pressure of flow in the smaller blood vessels, the blood vessels open up. And because the blood vessels open up, one can really have a good revascularization, thereby changing the entire approach or the outcome to a diabetic foot. And not only that, today we have objective evidence. There are certain scans, perfusion scans, which are done after revascularization, which just because of the color coding can tell whether the foot is adequately or inadequately revascularized. So these two things, that means covering the defect and revascularizing the part, have again changed a surgeon's approach to diabetic foot. So as a diabetic foot surgeon, I look forward to a little better understanding about the disease. I look forward to help from surgeons or plastic surgeons who would cover the defect, the revascular people, the vascular people who can actually revascularize my limb. And then coming to what we are going to discuss today is the help of an orthopedic surgeon. I had the privilege of working with some of you all, as I mentioned, to extremely good results, to an extremely comfortable level. And it is where my work as a diabetic foot surgeon stops. Your deformities like this, which are all because of the glycation end products of diabetes, I have no control over this happening unless the patient comes to me very early and I give him corrective footwear, or I counsel him about a lot of things in foot care. But when I see this foot, earlier it was thought that this person is destined to have a callosity, an ulcer, and then ultimately osteomyelitis. No longer. All I have to do is to refer this surgeon, this patient, to an orthopedic surgeon who would correct. And therefore, as I mentioned in the beginning, I'm not going to show case presentations because the results, the mechanics behind this would be best told by an orthopedic surgeon. But as a primary surgeon, it is my duty to identify an orthopedic problem and identify of something which is correctable, and then make the right reference so that ultimately the patient's foot can be saved. An extreme case of hammer toes. These toes today or tomorrow or day after are going to have pressure points all along the toes, multiple callosities, and literally one by one, the distal phalanx is going to be resorbed, osteomyelitic, infected, ultimately leading to what we call a toe-by-toe amputation in a patient. Again, a correctable deformity. When we used to see these calluses again, a forerunner to, if not a major debridement, is likely to have or undergo a major below knee amputation. All Charcot's foot, all deformed feet, all soles which were rocker bottom. In the beginning of my practice, I almost used to think that there is no hope for this patient. But today, with more and more understanding, with more and more better results being seen, done by orthopedic surgeons, where a deformity is corrected, a patient can have a reasonably good walking with all the precautions explained to him. Again, a chronic callus not healing, some changes in the bone, understanding the biomechanics of the toe and the foot can be life-saving, because if such a simple innocuous looking callus is not treated, this is the patient who is ultimately going to land up with a major toe amputation or a foot amputation. Again, some of the slides, this patient we had, a patient with hallux valgus, having a callosity, resistant, losing one toe, just tired of the foot, with correction is now callus free or ulcer free almost for about 3 years. But in spite of all this understanding, in spite of all these biomechanics, in spite of all the faculties involved, we still see this unfortunate side of bilateral amputations. Diabetic foot is a huge entity to be really taken care of, because this is something which is not acceptable to us in 2020. We continue seeing large necrotizing fasciitis, large problems, in spite of, as I told you, a good understanding. So, dear friends, today, as I told you, my job was very simple. Today, for me, it's a learning procedure. I'm going to sit back and listen to what all more corrections, what all more things you all can offer. But my aim as a diabetic foot surgeon is just to change the perspective. And I keep showing this slide because this slide is very dear to me. It has been an old slide. As you can see in this slide, you see from behind, and you see probably that this is a park. No longer this is seen in the COVID era. Social distancing important. But here, this is a boy and maybe a girl. But if you change your perspective and see the same problem or the same issue from the other side, you see a completely different picture. So we have to now change our perspective to diabetic foot from just a debridement or an amputation, from that to giving what is called a biomechanically viable foot. It shouldn't just be a foot, it has to be viable, it has to be biomechanically sound so that the person can walk on this foot. And for all this, as a surgeon, we require some basic thing. This is again a slide which is dear to my heart, that even the Lord had washed somebody's feet at some time. If the Lord could wash somebody's feet, I think as diabetic foot surgeons, if I touch somebody's foot, if as orthopedic surgeons, you all are going to touch the foot and actually going to make a difference in that foot, I think a lot can be achieved. Dr. Satish, thanks a lot, because it was a good opportunity to interact with all of you all. Just set the ball rolling. But before, this is not my last slide, this is my second last slide. Diabetic foot slides are all so-called dirty slides. As I told you, I still have those bad memories of all our patients in the veranda with a Macintosh and some smell around. So to end, I think we must have a pleasant note. I want to show the best legs ever. And these are the legs of Jennifer Lopez, which I think should leave a sweet in everybody's mouth before I end my talk. Thanks, Satish.
Thank you, sir. Thanks for this excellent talk. You actually took us back 25 years down memory lane at Sion Hospital.
Yes.
And the perpetual war with the general surgeons as to who is going to manage this patient.
But you all always won. We had to manage those people that time.
So we had a lot of other crap to manage. So. Anyway, moving ahead after this, we go to infections. And friends, infection in a diabetic ulcer or a diabetic foot is a nightmare and actually needs to be tackled on a war footing. Very often, even the MRIs that we do are unable to tell us the difference between osteomyelitis or bone edema in a Charcot's foot. So we need to understand how to tackle infections in diabetics, whether open wounds or occult infection, and kill the infection before the infection kills the foot. For this, I now invite Dr. Agashe, he needs no introduction, to take us through identification and optimum management of infection in a diabetic foot. Dr. Agashe, sir. Dr. Agashe, sir, is with us? Yes. Dr. Agashe, unmute करायला लागेल, sir.
Sorry.
Yeah.
Is the screen visible now?
Yes, sir. Full screen करून टाका.
Yeah. At the outset, thank you very much, Dr. Mutha and IOACON team, and of course, Dr. Rege for setting the ball rolling and giving us insight into the diabetic problems. I sincerely thank my friends who helped me in managing diabetic foot, the diabetologist, the plastic surgeon, Dr. Baya and Dr. Abhishek Kini, who is our foot surgeon. These are some of the most challenging things in diabetes, diabetic foot infections or diabetic foot osteomyelitis. Very often they start as ulcers, which could be because of external pressure or internal pressure in a setting where there is a peripheral neuropathy as well as peripheral vascular disease. All this would lead to diabetic foot infections, and added to that often are the injuries, because many of our patients walk barefoot in spite of repeated instructions, which leads to injury as well as foreign body insertions. Today I will discuss diabetic foot infections, either soft tissues or bone, and the ulcers would be tackled later on by my colleague. These infections, often at least 60 to 70% of ulcers get infected. The soft tissue infections are actually more severe and often have worse prognosis. The osteomyelitis is present in about 20% of moderate and 50% of severe infections. These osteomyelitis, unlike our classic hematogenous osteomyelitis, they are often secondary to the ulcers. So therefore, initially the cortex is involved, part of the cortex is involved, and later on medullary cavity is involved. So it is outside in and not inside out. We will make it more of case-based discussions. These are often inappropriately treated. So a 55-year-old man came to us with was a known case of diabetes. He had developed a small abscess on the dorsum of foot, and he was applied honey and sand, and after about 5 days he became absolutely toxic and brought to us in septic condition. So first and foremost, very often it is said that it's a late diagnosis of infection, it's a delayed referral, and inadequate or appropriate treatment. These are some of the very common things in diabetic foot infections. When we removed his lap, you can see that there are several skin lesions, but it still appears that maybe part of the skin may be intact. Now, one has to remember that this is just a tip of iceberg. Once you start debribing, you will end up with a huge defect. So what you see from outside is just a tip of iceberg in diabetic foot infections. Another important thing, as I said, the diabetic osteomyelitis is often because of the ulcer. So as you can see here, there is a ulcer which is developed in a non-healing ulcer over proximal phalanx for a long time. Now, very often these infections can progress along the tendon sheaths. So here you can see, we noticed that the hind foot, there was a fluctuant swelling, the skin was red. did an MRI which showed osteomyelitis of the talus, which you can see it has certainly, the pus has traveled from outside to inside. That's when we took the incision on that, you can see pus there, and the flexor hallucis tendon was already torn with the granulation tissue there, which led us to talus. So in short, the infections can spread way ahead along the tendon sheets. This is what debridement we did. Unfortunately, I don't have the follow-up photo, but then this took almost 2 months after skin grafting. This is about a case I had treated almost 16 years ago. As I said, soft tissue infections are challenging and often the reason for amputation. Now, this middle-aged man, diabetic since 15 years, tobacco consumers, was asymptomatic till about 8 days ago and presented to us with very high fever for a week, severe pain and swelling, discoloration of great toe, foul smelling discharge since 2 days, and very high WBC count. Here you can see that's the line I have marked. There was absolutely cold or markedly decreased temperature on this side. So this is the area, and this is the area which the skin was already dead, and we were sure that the inner tissues also were dead. So what do I do? Here I have a tobacco chewer and a diabetic, asymptomatic for 8 days, foul smelling discharge, diminished sensations, toxic patients. Do I do an MRI? Do I have time for an MRI? Now the issues are, this must be a very virulent organism. There's a foul smell, so very likely to be anaerobic. There's no time at hand. I have a toxic patient and I need to address this infection ASAP. I need to drain his pus, whatever it may be. I need to amputate. Question is at what level? I need to debride first and then take a decision of amputation. Now we realize that the temperature here was much less. So obviously we are talking of excising this.
Sir, your Dr. Agashe. Sir.
I think we lost connection with him. His photo is on still.
He'll join back in a minute. Meanwhile,
It's a problem with the internet, Ashok?
I think so.
Oh.
He's here.
He seems to be logging in again, right?
Yes.
Should I call up, sir?
Shall we continue with the next one? Because sir's anyway cases, so we can catch up later. Dr. Satish, what do you think?
Just give me 1 second.
Sure.
One call with. Ashok. Ashok?
Yes, sir.
Hey, sir is not picking up the call. Should we wait for him to log in or?
I think we can go ahead.
Okay. So while Dr. Agashe fixes up his glitch, may I now request Dr. Kurchatkar from Goa to
Can you see,
talk on management of non-healing ulcers in a diabetic foot.
can you
Dr.
see my screen?
Dr. Kurchatkar comes from a state which is still vacationing and the party is on, and the coronavirus has probably not gathered the guts to go. So Dr. Kurchatkar, over to you.
Can you see my screen?
Yes, we can.
Okay. Thank you very much. Yes, we are lucky, but still the number of COVID cases are rising.
No, we cannot see your screen, sir.
Yeah, you
No?
need to.
Please share your screen.
It just changed the view, sir.
Just a moment.
Yes, we can see now.
Okay, right. Thank you, everybody. I think let me speak on the topic that I've been assigned. Thank you very much to IOACON for inviting me to speak on this. And the speakers before me have really made it easy for me to present this, because eventually the manifestation of the diabetic failure treatment is managing an ulcer. So, as Dr. Agashe and Dr. Rege has already mentioned about how a multidisciplinary approach is the key to success in treating a diabetic ulcer, we never treat it alone. And most of the reason why these treatments don't work is because we try to meddle on with the ulcer by ourselves without understanding the pathophysiology. So we need to involve the surgeon, the orthopedic surgeon, the diabetologist, the microbiologist, the vascular surgeon, plastic surgeon, the orthotist, the wound care nurse, and most important is the counselor. Because there is a lot of frustration in these patients. They tend to wander from place to place. So education of this patient is extremely important. The trishul or the triad of ulcer formation is basically the sensory neuropathy that occurs in a long-standing diabetes, the deformity that occurs eventually as a result of motor neuropathy, causing all the hammer toes, the claw toes, and the cavus foot, and also the CHARCOTs. And the third thing is the repeated trauma, which finally, puts the nail in the coffin. So it is very important for us to understand that, to identify what is at risk before even the ulcer occurs. There are a lot of telltale signs which start coming up on the foot. First is the loss of sensation. So doing a proper neurological examination is very important. Look at the deformities. Wherever there is a deformity in the foot, those are the places where the ulcer is going to come up. A deformity, as I said, could be because of CHARCOT or a motor neuropathy. To add to it, if the patient has a peripheral arterial disease, a poor glycemic control, pre-ulcer lesions like corns, callosities, or infected nail beds, previous history of ulcer, long-standing diabetes, ill-fitting shoes, and history of associated chronic renal insufficiency. So these are the areas where you've got to be keeping a watch on whether the ulcer is forming or not. But one stage before that, we have to see the pre-ulcer lesions. We cannot take these lesions lightly. These are the ones which are eventually going to break down and land up. So anybody with a dry skin has a higher chance of a skin ulcer, or a small in between the webs. If there is a small ulcer, it can grow up and cause an amputation of the toe. So identifying these pre-ulcer lesions are extremely important. Or the hot spots, which can occur in a hammer toe or a pull-out toe. On the clinical evaluation of the diabetic foot ulcer, we first start with the plain visual inspection of the diabetic ulcer. Look at the location, the size. Once you have seen the size, then you need to understand the third dimension of the ulcer, that is the depth. Because this is where the real treatment modalities will change. And the depth assessment has to be done by probing the ulcer, and we have to probe deep down to whatever we find in the base. It could be a tendon, it could be a capsule, it could be bone. Because if the ulcer is deep down to the bone, you're already thinking of osteomyelitis, you're already thinking of infections. Once you have done that, when you have assessed the ulcer, assess the vascularity of the foot, either by simply putting your finger on the pulse, or you can use ABI. Look at the skin texture and temperature. So that will also give you a clue about the neuropathy. Look at the gait of the patient. The patients who have cavus foot or patients who are trying to favor the lateral border of the foot because it's fixed in supination, patient having a equinus, all these patients are going to have pressure points and are going to have predisposition to ulcer formation. Ill-fitting shoes, I think, is an underrated problem that we always tend to miss. So a tight toe box, one size smaller, or a general shoe which is very hard, these are the ones which can cause hidden damage. Look at the deformities, especially a Charcot's deformity, like a midfoot collapse, or all the hammer toes, hallux valgus, or a equinus gait. These are going to cause more problems. And a detailed neurological examination of all the sensations. For the ulcer, it is the three things that you need to see: extent and depth of the wound, if there is associated ischemia, and if there is associated infection. A simple ulcer without ischemia and infection is really not a problem, and it can be treated just by offloading. But presence of ischemia or presence of infection really adds to the problem. Wagner's classification system classifies into 4 grades. First 0 is no open lesions, then the superficial ulcer. This is basically depending on the depth of the ulcer and associated gangrene or no gangrene. Again, another classification, similar one, but adds infection and ischemia as a very important component of the ulcer. So associated infection or ischemia adds to the grade. Now, as far as the principles of treating a DFU or a diabetic foot ulcer, the first and primary thing is, once you have understood the biomechanics or the pathophysiology of the diabetic foot ulcer, is you have to offload it. It is the key in allowing the ulcer to heal in a normal way. The diabetic foot ulcers don't heal because they are not given rest. The shearing forces on the ulcer keep on coming. So offloading of the ulcer. Then coming to the ulcer management proper, which is debridement, dressings, infection control. If there is a deep infection, you need to treat with specific antibiotics rather than a broad spectrum antibiotic if there is a chronic ulcer. Once you have done this, it is also associated blood flow, because if there is no good blood flow, these ulcers are not necessarily purely a neuropathic ulcer, they are neuroischemic ulcers. So look at the improving modalities to improve the blood flow. Correction of deformity. As Dr. Rege has mentioned, that the orthopedic surgeon plays a key role here in providing a plantigrade foot, which distributes pressure in the entire foot area rather than locating it on the bony end parts. Optimizing metabolic functions. Here, a diabetologist will play a big role in controlling all the other parameters like lipids, blood pressure, and creatine levels, control all the comorbidities, and cessation of smoking if the patient is a smoker. As I said, offloading, now the best way to offload any ulcer is a total contact cast, which is non-removable, knee-high, but this is not always possible in a case where an ulcer is associated with infection or patient has an ischemia. In this case, it is better to use a removable total contact cast. This is the best way to offload an ulcer. The cam walker can also be used. The crow splint is used in CHARCOTs because it also offloads the entire foot. Things like toe spacers, felted foam, or a short ankle-high offloader can be used. Another way of offloading is by doing a TL lengthening. So that in an equinus foot, when the pressure is on the forefoot, if you do a TL lengthening, it gets a plantigrade foot, and that's another way of doing a offloading. As far as the ulcer management is concerned, you need to debride. Sharp debridement to healthy margins, provide a moist dressing environment, and start on empirical oral antibiotics. If the ulcer is deep, you need to go deeper, debride deeper, and see that you drain any cavity that is possible in the planes. Decompress all the compartments. In a deeper ulcer, you will require a hydrocolloid or arginate dressing because a lot of exudate. Start on parenteral antibiotics in the deep ulcer, and also plan for a revascularization procedure if the ulcer does not heal. In actually the dressings, though they have to be done every day by the nurse or by the whoever is available, the treating doctor has to assess the ulcer every week. What do you assess? You assess the depth of the wound, because there's an 85% chance of osteomyelitis if you have a probe to the bone in your assessment of the ulcer. Degree of exudate, the degree of infection, and ischemia. You suspect osteomyelitis in an ulcer if there is a visible bone or a probe to the bone. If the ulcer is more than 2 centimeters square, it is more than 3 mm deep, and there is an associated elevation of the ESR. In this condition, you will have to get an X-ray or other modalities, an MRI to confirm the osteomyelitis. Now, type of ulcer dressing is something which is very, very important, and generally we try and use the same type of dressing for all ulcers. Now, this doesn't serve the purpose. The ideal dressing should be actually maintaining a moist environment, but sometimes in an exudative wound, you require a dressing material which absorbs that exudate. So a moist gauze dressing soaked in saline is fine for a superficial ulcer. It does support autolysis. Sometimes an impregnated dressing with silver is useful for superficial ulcer. Hydrocolloid and hydrogel dressings like an intrasite gel, usually even for dry ulcers. Calcium alginate and foam dressings for deep exudative ulcers. Hydrofiber dressing again for exudative ulcers. These are some of the basic dressings that are available as per the exudative ulcer or the dry ulcer. Now, sulfur sulfadiazine, bacitracin, neosporin, and cadexomer iodine are some of the topical antibiotics that can be used in infected wounds. One word of caution here is that if we avoid hydrogen peroxide, povidone iodine, or a dipine solution in healthy ulcers because it tends to damage the granulation tissue. So as the wound is getting healthier, try and just maintain a moist environment instead of using such hard antiseptic solutions. Sometimes in a delayed healing, once you have achieved all the possible ischemia correction, infection control, and still the wound doesn't heal, then sometimes growth factors can be used. Sometimes you can use, if the wound is very exudative, a lot of debris, you can use a maggots for a biological debridement. Vacuum-assisted closure, pulse lavage, ESWT are all techniques which have been used in all of those chronic non-healing ulcers. Providing high level of oxygen to the wound also helps by either using an HBO therapy or an oxygen mist or an ozone therapy. Now, as Dr. Agashi had said, control of infection is extremely important. These wounds are usually polymicrobial. By the time they reach you, there is not generally may start with staph or a strep, but once they come to you within 4 weeks, 6 weeks, 3 months, they are usually having a combination of gram-positive and gram-negative bacteria. In addition to that, if it's foul smelling, you have to look at obligate anaerobes. So parenteral antibiotics have to be started for deep infected ulcers. Drain all the abscesses, open out the dead spaces, be very aggressive with the debridement, saucerize the wound margin so that everything comes out, decompression of the compartments. And once you've done the culture, start on a very specific antibiotic for the best response. Improving tissue perfusion here, either by doing a percutaneous transluminal angioplasty or a bypass, is indicated in those patients where the ABI is less than 0.5, a toe pressure less than 30 millimeters of mercury, or a transcutaneous PO2 of less than 25, or if the ulcer is not healing by 6 weeks. So we have to think of improving the blood flow in all these conditions. Certain special procedures that can help in correcting the non-healing ulcer are corrective osteotomies, so that you create a plantigrade foot. Sometimes you get a midfoot collapse and you get a rocker bottom foot, and the pressure comes in the midfoot. Sometimes the metatarsal heads drop down. So you have to do this corrective osteotomy to deload the ulcer. Sometimes you may have to resect the metatarsal heads. Sometimes you have to do an ostectomy of the protruding bone, a TA lengthening procedures, revascularization for intractable ulcers. Sometimes it is necessary to use xenografts or sometimes some synthetic grafts like an appligraft. So I'll just go through a single case before I end my presentation. This is a 55 male diabetes since type 2 diabetes since 15 years on oral medications, non-smoker, normotensive, no peripheral artery disease. He has altered lipid levels, non-healing ulcer for 6 months. He has a midfoot plantar ulcer, necrotic, very exudative ulcer, loss of sensation, peripheral pulses normal, and a midfoot collapse. So this is how he presented, which is a 3 months old non-healing ulcer, which is a very, very common thing to happen. Now the ulcer assessment, it was 5 by 4 by 3 centimeters, probing bone deep. So I could feel bone at the base of the ulcer. The culture report came as staph plus enterococcus. So I managed to start this patient on IV lineage plus tazobactam for 2 weeks and then put him on oral lineage for 4 weeks and just did moist saline dressings and added a mega heal ointment. The X-ray here showed, you can see how at the base of the ulcer, you can see the bone protruding or the cuboid has actually subluxated downwards. And that was the bone that was protruding, which we had to do a ostectomy so that to relieve the pressure from the skin. This was the ulcer after 1 week of ostectomy and silver dressings. 2 weeks post-op, gradually shrinking. I have another picture which I couldn't find. The wound is just now 2 by 2 centimeters. What is most important here is the offloading. We on the right side, the ulcer is on the left side. The right side, I have put a offloading shoe for him to prevent further ulcer formation. On the left side, this patient has a CHARCOT arthropathy with a subluxated cuboid. So we designed a offloading sole with a pro splint, which is the ideal thing for combo like this. So finally, the ulcer treatment is a team work. We cannot be treating it by ourselves. We have to involve all the people at any stage, whatever the surgeon, the vascular surgeon is required or the orthotist is required, and that will have the best results. Thank you.
Thank you, Dr. Kurchatkar, for your exhaustive talk on ulcer management and providing us an insight into it. Dr. Agashe, sir, are you back with us? Ashok, is Dr. Agashe, sir, back?
Yeah, I joined. Sorry.
Oh, great, sir. Great, sir.
I lost
Sorry.
my connection. I had to connect by mobile.
Great, sir. So we resume where you left, is it?
Okay. You have any idea? Because I just kept talking. I finished my talk and realized that
we were you had started with showing one case where the toe had become black and the 51-year-old diabetic with a smoker and all that. You had started a case presentation. Yes.
The slide number 17.
I think this is where I was.
Slide number 17, where you show the foot photograph. That is loss of skin and soft tissues. That slide.
Yeah.
Yes, this one.
Yeah. So that's the loss of skin and soft tissues we had. We amputated the great toe, excised the necrotic skin on both sides, realized that the infection was from dorsal to plantar aspect. The second and third metatarsals were totally devoid of any soft tissues. The skin, even this skin, was non-viable. So obviously, we had to amputate at hind foot, and the culture, as expected, turned out to be B group Streptococcus agalactic, which is a source of morbidity and mortality in high-risk population. So that is why he was so toxic, and the disease had a very short duration, very aggressive. He had to be started on piperazine, tazobactam, linezolid, and this is at 4 months. He is walking quite comfortably with orthosis at this time. Another patient, again swelling discharge. He was not sure when, but not more than 3 or 4 days. Both dorsalis pedis and posterior tibial were not well felt. We had to do Lisfranc's amputation, and this is him at 7 months, and that's the range of movement at 7 months. Another very troublesome infection, as mentioned by Dr. Rege, necrotizing fasciitis, or infection with flesh-eating bacteria. Though it does occur in non-diabetic patients, in diabetics it is common and can be very aggressive, can be life-threatening, progressive, and as shown here, there is a infection of the deep fascia and it dies with secondary necrosis of skin and subcutaneous tissue. So this patient, 70ish, presented with swelling for 3 days. When he presented, he was in hypotension, hypoglycemia, drowsy. We had to start him on NORAD and vasopressin. We had to intubate him. His WBC count was very high. And that's a kind of debridement we had to do. And then, of course, moment we did debridement, he started settling. This is at 10 days and this is at 18 months. Now coming to diabetic foot osteomyelitis. As against our classic hematogenous osteomyelitis, this is generally a soft tissue infection which spreads, involves cortex first and then the marrow. Forefoot osteomyelitis is the commonest, but the prognosis is worst with hindfoot osteomyelitis. As many as 50% of patients with hindfoot osteomyelitis land up with amputation, as against just less than 1%. I'm talking of below knee amputation. Clinically, it can be suspected or diagnosed if the ulcer is more than 2 centimeters square, and if you probe and if you feel the bone, of course you need to use a sterile probe, but if it reaches the surface, bare bone, then it is very, very likely that you are dealing with osteomyelitis. Of course, if you see visibly necrotic bone or sequestrum, obviously the diagnosis is already made. One needs to, of course, take X-rays, MRI, bone scans, and PET to assess the exact extent of osteomyelitis, whether soft tissues are involved, whether the infection is spreading along the tendon, and so forth. Generally, treatment of osteomyelitis surgical, which would involve removal of necrotic bone, excision of the ulcer, correction of deformity, and plastic reconstruction, supported by antibiotic and the medical management, generally in phase state. One very challenging situation is calcaneal osteomyelitis, and as shown in this paper, almost 50% land up with amputation and the mortality is almost 25%. So one has to be very, very careful and one needs to be very aggressive while dealing with calcaneal osteomyelitis. Now, a case to show that it is quite difficult to differentiate between inflammatory stroke Charcot and infection in a diabetic foot, and one has to have very high index of suspicion. Now here, this patient, a middle-aged man, controlled diabetic, but he had Addison's disease and he was on steroids. The MRI was reported as inflammatory arthropathy. Therefore, he was just continued on conservative treatment. Over the next 3 months, he deteriorated significantly. He could not walk without support. The MRI and X-rays progressed significantly. The navicular was totally destroyed. And on exploration, you can see there was a pus at the navicular. Almost the entire navicular and part of cuboid had to be excised. Part of the cuneiforms had to be excised. The culture report was MSSA susceptible to cephalosporins. He was on antimicrobials for 9 weeks. And then after his inflammatory parameters settled, stage 2 was done to reconstruct this defect and support this defect using a plate. This was filled with allograft, bone marrow aspirates, and added with vancomycin. And this is him at 7 months. He walks unsupported. So it is very, very important that in diabetics, one has to remember the classic signs of infection may be missing. You should possibly err more on the side of infection and do a biopsy. Addressing poor supply, there is no point in doing any vascular repair or procedure at late stage. If at all, needs to be done early. A word about samples and tests. Swab cultures to be avoided. Avoid collecting samples with a swab from the from the sinus. We need deep cultures. Need to collect them in sterile leak-proof containers as shown in the previous case, preferably more than one sample. And it is important that every lesion that is cultured should be sent for histopathology. Most of these severe life-threatening infections are mostly because of gram-negative and anaerobic bacteria, and 75% of patients have polymicrobial infection. And therefore, when after or surgery or after you have collected sample, you need to start antibiotics for those 2-3 days before the results come. You need to possibly have combination of antibiotics. Now, which antibiotics? Now, generally antibiotics with decent bone concentration and good oral bioavailability should be used, but they should be targeted. That means based on antibiotic report, culture sensitivity report. The common antibiotics that are used generally with combinations are fluoroquinolone, sulfonamide, cyclines like doxycycline, minocycline, tetracyclines, macrolides like erythrocin or clindamycin, rifampicin. A word about rifampicin is always after bacterial load decreases. That means only 4 or 5 days after debridement is done. Always as combination, never singly, and possibly as a last resort. Fusidic acid often was used as ointment, but now because of increased resistance to other antibiotics, there is renewed interest in oral fusidic acid and linezolic acid. So most of these antibiotics can be used generally with as combination because most of these are polymicrobial. So to recapitulate, 50%, half the patients with severe diabetic infections will have no systemic signs or no symptoms of infection. Soft tissue infections are often more fulminant and responsible for acute amputations. Late diagnosis, delayed referral, and inadequate treatment are common in diabetic foot infections. Controlled aggregations and stage procedures are needed in diabetic foot osteomyelitis. Avoid long-term empirical antibiotics. What you have to do is antibiotics only after culture sensitivity studies. And of course, general treatment, offloading, addressing diabetes, and addressing other comorbidities is very, very important. Thank you very much, friends, and thank you for the technical problem. Thanks a lot.
Thank you, sir. Thank you very much. As always, it's a great pleasure to listen to you and always a great learning experience.
Thank you.
As Dr. Agashe pointed out, the diabetic foot can affect any part of the foot, but the hind foot problems are the ones that give the maximum morbidity. I now invite Dr. Sampath Patil from Pune to take us through the various problems that can occur in the hind foot and how to manage them. Sampath, over to you.
Thank you, sir. Am I audible now?
Yes, you are audible.
So I'll be talking on hind foot charco and basic things. What are the issues with charco foot? I will address. What are non-surgical and then surgical reconstruction of hind foot. Charco is a term coined after this person, but basically he explained this in syphilis because that time diabetes was not there. Neuropathy was diagnosed in syphilis, but same thing we see in diabetes now. And apart from diabetes, alcoholic neuropathy or some issues with the spine, spinal cord injury and leprosy, even we see charco in these conditions. Generally, they are not associated with peripheral vascular disease, but if it is with peripheral vascular disease, then it is a really issue for healing. Issues are ulcers, infections. We have seen both issues now, so I'm not going to touch the ulcer and infection part, but look at this particular gentleman, how he walks with severe crooked deformity, but still painless. Obviously, when we see such kind of patients, they have diabetes, neuropathy, and painless deformities, or pain is there but it is out of proportion to the deformity. So they are charco feet. What are symptoms? They are swollen feet, deformed, there may be erythema, pain. There may not be a history, significant history of trauma, but definitely you will find out impaired sensations in them. Now, whether some person will develop charco feet or neuropathy, is it dependent on severity of diabetes? No. So many doctors we have diagnosed to have charco feet when they were under impression that my sugar is maintained well, so I won't develop neuropathy or I won't have charco feet. That's not true. So it is independent of the severity of diabetes, its duration, or its type, whether type 1 or 2. We know these stages. I'm just posting this slide to know that there is a stage of fragmentation, stage 1, then stage of transition, that is the stage between these two, fragmentation and consolidation phase. So stage 3 is consolidation. Why? As a surgeon we should know it, because any person who touch patient in stage 1 or fragmentation stage, it's a really little aggressive phase where your reconstruction may or may not work. Anatomic classification, we know midfoot charco is most common, then hindfoot charco, and of course when ankle and calcaneum is involved like this. Now, important aspect, clinical features. Most of the times we have seen that acute charco is confused with cellulitis, and when we receive patients have taken so many antibiotics. But one simple thing, one simple take-home message from this talk, even if we take, that if you elevate the swollen foot of charco for 5 minutes, its redness will decrease. It will never happen in infected foot. So anything which has to be differentiated from cellulitis, just elevate the limb. If it reduces, it's charco, and if it doesn't, then it is infection. So you can avoid giving antibiotics to this limb, because acute charco is usually confused with cellulitis. Neurological examination is important, but most important is this joint position sense. We have to diagnose this clinically, and so many times we test this joint position incorrectly. Like this person is testing it from side to side but touching other toes. Patient is going to know where is the toe, up or down. Here he is holding it from the superior and inferior aspect. It is again a wrong method. You should hold it from side to side. Don't press it too much, and don't touch it to the other toes. Try to evaluate joint position sense, and most of the times charco feet can be diagnosed clinically. Radiological appearance, we have to keep this X-ray in mind. Sometimes this X-ray, when it is atropic, it is misdiagnosed as osteomyelitis. So as an orthopedic surgeon, we should know that this is not infection, but this is atropic type of osteomyelitis. And this is a common picture where it is hypertrophic picture, distended joint, dislocation, debris. This is more common, but even atropic is there. We should know that charco feet, weight-bearing X-rays are very important, because non-weight-bearing X-rays look perfectly aligned. But when you take weight-bearing X-rays, they're all dislocated and displaced. So weight-bearing X-rays are very important. How do we diagnose? As I said, clinical is most important. And anyone who has diabetic neuropathy with swollen foot, he or she has charco foot unless proven otherwise. And X-ray may be initially normal, but weight-bearing X-rays are important. Now, what should be the aim of treatment? It is to make the foot plantigrade and keep it ulcer-free, either by operative or non-operative measures. Non-surgical measures, we just heard from Dr. Mahendra, but it needs team approach. It needs everyone to get in, right from vascular surgeon, general surgeon, physician, plastic surgeon. Everyone has to give the contribution. We have to have orthotist with us, coach who is very helpful in managing the deformities. I will just go through some cases. He's a 70-year gentleman obviously neuropathic foot. Look at this, how he is walking. He's walking on his middle malleolus. Can you imagine? When I asked him what was the issue, he says, no, there is little deformity and I don't have pain. But look, then why you need to correct this deformity? I will play this video again. Now, if he keeps on walking like it, he will develop an ulcer on the middle aspect, middle malleolus. So we need to correct this deformity, not for only the sake of deformity correction, but we have to give him plantigrade foot, which is ulcer free. Look at these x-rays. Weight-bearing x-rays are absolutely displaced bones. Head of talus is here. See, the head of talus is absolutely down. In fact, not on middle malleolus, he is walking on head of talus. This is head of talus. So it is totally dislocated foot. We decided to reconstruct it. Obviously, we have to explain what should be the prognosis. We did TTC fusion, transfibular approach. We reconstructed his hind foot. And then when this we did in Kolkata, when I went for follow-up after a few years, look at this. Whenever we do these cases, we tell them that neuropathy was there preoperatively and neuropathy will remain same post-operatively as well. So if he or she does not take care of these this neuropathy, then even your implants will break. See, I told him to put on brace. He did not. His nail broke, but fortunately he had a good fusion, sound fusion. So he sent me a video almost 2 years after the surgery. He's walking well now. See how nicely he's walking. He has got a plantigrade foot, ulcer-free foot. But we have to counsel the patient that he or she needs to put on the brace because still it is a painless foot and they may overstrain the foot and deformity may recur. Another case where he's a gentleman walking on almost middle tibial plafond, dislocated medially. We went ahead, did TTC fusion, surgical reconstruction, went on to heal well. And these are his follow-up x-rays. This is his alignment, good plantigrade foot. But every time this may not happen. Sometimes even we are happy with the fibrous union. Every time bony fusion may not occur in hindfoot reconstruction of Charcot because of movements, neuropathy, we may end up in getting fibrous fusion. So what I tell my patients is to protect the feet even if we make them plantigrade. So severe deformities, if we are correcting them, what I tell my patients is we are making your foot braceable. That means I am correcting the deformity, but still you continue to use the brace. Okay. And sometimes we may not be able to achieve even fibrous union. That this is a lady, a diabetic lady. She had such kind of fracture, which was fixed with this particular fixation method. It was satisfactory. Unfortunately, it fell apart and it was absolutely unstable, dangling limb. I was involved. I did TTC fusion. Everything went on well. After 2 months, soft tissue healings, 3 months soft tissue healing was good. But look at this again. Sorry for this X-ray, but I got same X-ray here. We got her swelling in this manner, and her X-ray is not doing good. She is either having active Charcot here or infection. So every time we do reconstruction, this may not heal on to a sound bony fusion. So we have to explain the patient that even if we land up in fibrous union, we have to continue the brace. Now brace has to be on, or sometimes we may not be able to go to the fusion or union. To summarize, non-surgical and surgical measures in a team approach are important in salvage of Charcot foot. Fractures, dislocations, ulcerations are definitely issues in Charcot. Aim of hindfoot reconstruction is to make the foot plantigrade, ulcer-free, but still mind well, you have to use the brace. Thank you so much.
Thank you, Dr. Patil, for this crisp and very informative talk. I now invite Dr. Pradeep Munot to speak on CHARCOT's involvement of the midfoot and its management. Dr. Pradeep.
Can you see my screen?
Yes. Yes, it's seen.
Good, thank you. Thank you so much, Dr. Satish Mutha and the whole IOCON team. It's a privilege to be part of this IOCON Bounce Back program. So without further ado, I'll start. So Dr. Sampath Dumde Patil has nicely spoken on CHARCOT. So that makes my life easier, where I won't be going on how to diagnose CHARCOT. But the key thing is, how do we manage the midfoot CHARCOT? So my aim would be, how do you manage, when do you do conservative, when do you do other options, and what kind of fixations you can look at. So let's start with a case of 45-year-old male chap who is an Indian, stays in Chile, has diabetes for more than 15 years, hypertensive, came with swelling of the foot, treated as cellulitis with antibiotics. This was the kind of foot he came to us. In Chile, he had a vascular artery Doppler, both arterial and venous. He had an angiography, and they thought it was a DVT or an arterial thrombus, to an extent that he was advised a vascular surgery. Investigations were done. Hemoglobin is low, WBC is normal. Rest everything was almost normal, and this is the kind of X-ray he came with. So this is a clear case of CHARCOT, as already pointed out and discussed by my previous colleagues. Now, how do you manage such kind of feet? So let's summarize. Brodsky's classification of CHARCOT divided into midfoot for 60%, hindfoot F10, ankle of 20, and a calcaneum tubercle, which is 3B. That's a small percentage. Now, it's all well and good, but it doesn't give any difference between the Lisfranc joint involvement, a navicular-cuneiform joint involvement, and the talonavicular joint involvement. If these different types of joints are involved, what is its clinical significance, and how does it affect the foot biomechanics? Why, as a surgeon, we need to know it is because these joints, when dislocated, behave differently, and the treatment protocol is different. And I would advise everybody who is dealing with CHARCOT to read this article by Lou Sean, who is a very good close friend of mine. In 1998, gave this classification on 131 patients, where he basically looked at these deformities and divided into the anatomic location of the maximum deformity, and further subdivided according to the severity of the deformity to stage A, B, and C. And I will go through this classification. It will take some time, but it's worthwhile because that gives you a treatment protocol. So the type 1, which he said the deformity, is the Lisfranc deformity. So the deformity goes through the Lisfranc joint. Now the key thing is these type of deformities gives a medial plantar prominence. And here is an example. Here you can see this is the prominence on the medial plantar side, and patients may get ulceration in these type of deformities. So again, here the ulceration develops medially underneath the medial cuneiform or the base of the first metatarsal. So that's a type 1 Lisfranc, which is one of the commonest. The second common is the navicular cuneiform dislocation, where the dislocation goes through the navicular cuneiform and into the lateral side through the middle and the intermediate cuneiform. And the key thing here to note is the dislocation of the fourth and the fifth metatarsal on the dorsum of the cuboid, and the ulceration which develops is on the lateral side, which is under the cuboid, unlike the type 1 where it is medial. So again, it's clearly seen in this picture. So that's your type 2. Now the type 3 is where the whole navicular gets involved. It is called as a perinavicular dislocation, which is classified as a type 3 dislocation. So here it is, a fragmentation of the navicular is seen clearly here. Medial column shortens, but the foot supinates and adducts. So what happens is here, again, the ulcer occurs laterally under the cuboid or the base of the fifth metatarsal as the foot supinates and adducts, but the medial arch is well bented paradoxically. So this is a perinavicular dislocation. And the fourth one is where it goes through the transverse tarsal joint, that means the talonavicular joint and the calcaneal cuboid joint. It's not very common, but here you can see these examples. But in these cases, the ulcer will develop where underneath the head of the talus, and the foot may also, the deformities through the transverse tarsal. Either, as I said, the ulcer develops under the talus head or under the plantar aspect of the distal calcaneus because the cuboid is dislocated dorsally. So these are the 4 types of dislocation seen in the midfoot. Now, how bad it is? So depending on the severity, so he is classified into 3 stages. Stage A is where the arch just lowers, which is called as a foot at risk. And these patients have very good prognosis. They can easily be dealt with in a conservative treatment by orthotic special shoes, and they are unlikely to get or need surgery. Now, stage B is where arch is in the same plane as the metatarsal head. So effectively, you have got a flat foot effectively, but it is not a rocker bottom. Now, we need to either treat them aggressively in conservative treatment or may require surgery. But the worst case is the stage 3, where you effectively patient comes with a rocker bottom foot. The plane is below the metatarsal calcaneum, prognosis is poor. There is a very high risk of ulcers and osteomyelitis, and surgeries are needed. Here is an example here of a stage B, and this is the example of a stage C, where a patient has already developed a rocker bottom and she is straight away going for surgery. And as a surgeon, you would want to differentiate between when a patient comes for the first time, are you going to treat these patients with conservative, or you're going to give a trial of conservative, or you're going to straight away say surgery. And that's what this classification system helps. I've already, I think Dr. Dubri Patil has already alluded it, and Dr. Agashe sir has already alluded it, how you differentiate between Charcot and infection by proper history taking. And the key thing here is understand if there is an ulceration of more than 4.5 centimeters square, there's a 3-fold chance that the patient may have a concomitant infection or an osteomyelitis. Elevation test has already been said, where the redness is reduced. You should be looking at blood tests, CBC, ESR, CRP, though in both the cases may not be elevated. Imaging modalities, as a primary physician, you would advise a primary physician not to go for CT, MR, and PET scan. As a treating orthopedic surgeon, you would want to get those scans done appropriately. Weight bearing scans are very important. PET scan, we have already spoken. MRI tells you the soft tissue infection on osteomyelitis if you're suspecting. And CT scans, I get them done to understand the kind of deformity you're looking at and the correction if you are planning for any surgeries. Now, looking at the treatment, the aim of the whole treatment for Charcot is to restore the alignment and stability of the foot so you can get a braceable plantigrade foot. Understand that it's a braceable plantigrade foot. You're not looking at a fusion. Contraindications for arthrodesis is if there's a flare, infection of the soft tissue or a bone. In acute stage of the IOACON coils, you're not looking at doing an arthrodesis. You may do something else, but not an arthrodesis. If the patient has a peripheral vascular disease, insufficient bone stock, or if the patient is not able to comply, I'm not going to go ahead and do a fusion for these cases. So what are the options? So when a patient comes with acute Charcot in a foot, midfoot, the first thing, as we have gone through stages and the deformity, would you offer them a total contact cast or a brace? Now that really depends on the setup which you have. Patients, if they're compliant, you can go for TTC and give them a plaster boot, or plaster and change in the initial 2 or 3 weeks because the swelling rapidly comes down, and then you can call them later for a change of cast every 3 to 6 weeks. Or once the swelling comes down, then you can put them in a walker boot or off-the-shelf orthotics. Now, I will also talk about what are the other options available for these. So bumpectomy or exhaustectomy, as I call them, internal fixations where you can use plates and screws and beam screws, or external fixator or Elizaro are an options for midfoot Charcot. If the patients really have initially ulcers, you can want to relieve the pressures, or you want to treat these ulcers before you want to go ahead and do any sort of internal fixation. And these ulcers can be treated by proper infection control, non-weight bearing status, metabolic control, and appropriate wound care, which has already been. I said, when do you do a bumpectomy? If a patient has a very prominent plantar or medial or lateral bony bump, which is impending on the skin, where the skin is about to break down, or if you have a non-healing ulcer and underneath you have a bone, and if the foot is stable, then you can go ahead and safely do a bumpectomy. Like these cases here, you can see this X-ray where there's a plantar aspect, wound is there, and this piece of bone is causing non-healing ulcer. What I do is I either go on the medial or the lateral side. I do not use a plantar wound, because once a plantar wound heals, there's a lot of scarring, and it can get it can open up once they weight bear as well. So that's how I would do it. So this is here before and after. That's a big bony bump present, and you want to make sure that that's been excised properly. Now fusions or arthrodesis is indicated where you have recurrent ulcers, deep infections, severe instability or malalignment, or as I said already before, the foot is unbraceable, unchewable, or failure of the corrections. The key thing in CHARCOT, in the midfoot, the surgical principles when you operate are you minimize the soft tissue trauma, to prepare the joint adequately to get a good fusion and stability. You have to correct the deformity in whichever way possible, and you want to make sure there is adequate stability. So the key thing, if you see in the last, I have put this adequate stability, and the stability can be then got by uh, beam screws, plates and screws, or an external fixator or a ring fixator. It doesn't matter. But the top three are the main important surgical principles. So in this case here, there's a rocker bottom type of deformity, and you want to make sure you take an appropriate wedge to correct that rocker bottom foot. It is a multiplanar type of osteotomies which you need to correct. Both either plantar correction has to be done, and suppose if it is abducted, then you need to do a correction on the medial side as well. And the K-wires can be used to guide the correction through the joints. So you have just one or two cases where there's a severe valgus type of deformity and almost a rocker bottom type of deformity seen in this case. That's the kind of wedge which was planned to take out both on the medial side. So effectively it is a trapezoidal, not just a single plane, it's a multiplanar. And there you can see the correction has been achieved with a nice correction both in the AP and the lateral plane with a super construct. When we talk about a super construct, we mean that you have a very long plate with long screws going not just into the on the medial side, going right across through the foot, and then you have beam screws as well, and that really gives you a stable construct. And this is at follow-up at 6 months. This arch has been well maintained, no pressures, no bony prominence on the plantar side. And that's your pre-op and your post-op correction. Another patient, again a valgus type of deformity present, and this has been corrected and maintained with internal fixations and beam screws both sides. This work of mine on the midfoot CHARCOT was presented by me at the AOFAS, which was accepted as a poster where we presented our work along with Dr. Arun Bal from Raheja. We had presented a series of 13 cases with excellent outcome. So in short, I have this algorithm for CHARCOT. I divided as, does the patient is ulcer free or is there an ulcer? If there is an ulcer, I put them in an external fixator for around 6 to 8 weeks and make it as a closed CHARCOT. And then I treat them as a non-ulcerated or no wound. The aim, as I said, is to achieve stable or plantigrade foot. And if it is ankle, we have already heard it is a TTC nail or a plate. While if it is a foot, then you either do a plate screws or a combination for stabilization. So in conclusion, you evaluate systemically, but also evaluate locally to make and evaluate the ulcers, ischemia, and what type of CHARCOT and what stage the CHARCOT is in. To get a successful CHARCOT reconstruction, if you use this checklist, it would be very helpful. So in your pre-op status, your HbA1c level is corrected, your vascular consultation is done, and make sure you have the best supply, whichever is possible. Patients are started on bisphosphonates because they have been shown to be very effective, and vitamin D3. And also new studies have shown that even teriparatide works wonders in these patients. Intra-op, prophylactic antibiotics, gastroc or TA lengthening, restoration of the medial column, you get a good rigid fixation with a super construct. Make sure you do bone graft, and orthobiologics definitely have a role. And post-operatively, you need to continue them with antibiotics, strict non-weight bearing for almost 3 months. You continue your bisphosphonates, vitamin D, good glycemic control, and always these patients are in special shoes or brace for at least a year. Thank you very much.
Thank you, Pradeep. Thank you for this nice presentation. You cleared a lot of doubts we had in mind about managing these tricky problems. From here onwards, we now move to Dr. Girish Motwani from Nagpur, and he's going to speak with us on the various kinds of amputations and salvage procedures that we can do in the diabetic feet. Dr. Girish,
Good evening, sir.
good evening.
Thank you, Dr. Satish, sir,
Yes.
Team IOACON for bringing me to this platform. And this is really a great privilege and opportunity for us to present our work on this platform. Today, my talk is limited to the level of amputation and the decision making about it. My most of the work is already being done by Dr. Regi, sir, Dr. Agashe, sir. And in my talk, I will try to focus on the decision making at the level of for the level of amputation. We all are aware that diabetes, it increases the risk of amputation by 20 folds, as Dr. Agashi and Regi mentioned. Disaster in the diabetes, as Dr. Mahendra has said, it always starts with the foot ulcer. You can see that a majority of the problem that brings the diabetic foot to the amputation is mainly because of the problem with the vasculopathy and non-healing ulcer, and on the top of that, if the infection settle, that continue to be the main reason for the lower extremity amputation. So the big enemy in the diabetic, we are already aware that this is a vasculopathy, which involves small vessel disease, large vessel disease, which may be accessible to the revascularization procedure, but many times it is a small vessel problem, cannot be cured or taken care by the revascularization of the endovascular procedures, and it continued to create a problem of ischemia. On the top of that, there's a polymicrobial infection which lead to gangrene formation, and finally the disaster happens. And majority of the time we feel that we need to go something different from just dressing and debridement. So this is a very important a chart from the recent debate published whether to ampute or not. And here are some points that what are the indications in which you can do the debridement or the minor amputation, and you should not go for the major amputation. So if you have a good blood circulation in your foot, and on the top of that it is infected, like only the neuropathy without a vasculopathy, these are the cases where you can get a success with just a debridement. Or when you have a small vessel disease with a gangrenous toe, majority of the time, if it is a dry gangrene, it auto amputates by itself, and you don't have to do a lot of work if it is just a small vessel disease. You can treat the osteomyelitis having a good blood circulation with just a debridement, excision of the metatarsal head, as you can see here. A lot of antibiotic-related substances. But do we waste the time trying to save some feet? And should we aim for local minimal surgery at all cost, or we should go for the, or are there any frank indications of primary amputations? So these are the real challenges which cannot be treated by just the debridement and the dressings, and you may require a major decision or the big stump amputation if you are dealing with such kind of foot problems. So this is a recently I did last week. This is a wet gangrene, active discharging sinus. Patient was a complicated diabetes. There was a lot of comorbid conditions, and finally it was landed with the amputation. So there are the true indications of doing the primary amputation. One is the wet gangrene, life-threatening sepsis, as already mentioned, the patient having the extensive muscular necrosis, or where the revascularization is not possible. So these are the indications where one should go for the primary amputation. So there are many health economic issues also if you just treat a non-salvageable foot with minor procedure, debridement, and the dressings. And finally, when it is landed with the amputation, the cost of the treatment goes very high. And clinician should always consider what is the best treatment for the patient whether the primary amputation or often a prolonged, expensive, failure-bound local aggressive surgical treatment. Because the aim of any treatment is to deliver the pain-free mobility, even if it is on a prosthetic limb. So many times you may require the amputation as a primary treatment, but it is not that simple. It is not just the amputation; it is the cutting of the limb and stitching the rest of the area. Amputation, it requires a lot of judgment, it requires a lot of planning, meticulous handling of the marginal tissue, and it is very important that amputation should not be treated as an admission to the failure. It may be the first step to return the patient to the successful mobility. But many amputations, as we see in our practice, done by untrained surgeon or without the preoperative planning, they are not successful. As you can see, some example here, the Charcot amputation was done, but there were a lot of abnormal scarring on the amputation stem, which are the pressure creating areas, non-plantigrade. On the second picture, you can see that this is a non-braceable deformity. The amputation is done just to save the limb, but the patient cannot walk, and he is walking on the lateral border of the foot, which is creating a lot many other problems. Or sometimes we see the amputation stem which is not healing. So it is not simple. You need to plan too much of the things before you are cutting any part. So these are the different level of the amputations which are mentioned, and let's see how we decide what is the level of the amputation we want. So first thing, look the patient as a whole. A aged patient, high age patient, they may not be able to tolerate the high level amputation, but simultaneously, if you do distal limb amputation, he may not be able to vascularize or heal that distal stump. So you have to look as a patient of the patient as a whole, look at the other comorbid condition, whether he is able to control the diabetes or he is on bad insulin dependency. A bedridden patient, functionally useless limb, life-threatening sepsis. These are the true indications of doing amputation, even in the emergency setups. And many times you have to look for the other conditions, medical conditions of the patient, and decide what is the best option for this patient. The second thing, look at the affected limb. Of course, the arterial perfusion, which is a main culprit, is important. So inspect the devascularized area, palpate the vessels, do the Doppler. ABPI you can do for the distal peripheral disease, but it is sometimes may not be 100% true, or may not be 100% evaluative of the ischemia. You may get a high ABPI having a bad PVD because of the calcification of the vessels. And majority of the surgeons, they judge intraoperatively by the bleeding levels. So what is the best level? So another things which you should look is neuropathy, biomechanical problems like any foot deformity, because we want the plantigrade braceable foot. Will the remainder of the foot be functions? Uh, for the general, if you see for the local amputation in the foot to heal, the circulation must be adequate. In practice, there should be at least one patent artery to the ankle level. Amputation is not successful if the remaining part of the foot is not functional. Look at the example here. He was a young patient, diabetic, non-healing ulcers, motor neuropathy. He was having the tight contractures of the Achilles, a non-healing gangrene of the foot, and he was amputated, was just like that, without the TA lengthening, without the tendon transfers, and it is a non-functional limb, equinus deformity. And look at the contracture of the Achilles here. So it is just a cutting of the limb, and this is a non-braceable, unstable hindfoot, which should not be the aim of doing the amputation. So we require the plantigrade and the stable hindfoot. You should do the Achilles lengthening or the other tendon transfers like the tibialis anterior or the peroneus longus transfer to maintain the to counterbalance the Achilles. Proximal amputation sometimes would have been better if the remainder of the foot is not functional. Another thing which you have to look at the foot is what is the extent of the infection. As Dr. Munut has said, is 4.5 is bad. extent of the gangrene, adequate, do you have adequate soft tissue to cover the wound, and what is the level of the bone we want to resect? Let's see in some case-based explanation. So what is the level of the bone resection we want? Generally, the partial amputations, they are rarely successful in the diabetic foot, or it is poorly tolerable conditions because they are always associated with some motor neuropathy. So if you want to take out only medial first ray, you can take out the lateral 2 rays, but no more than 2 rays should be amputated. Look at example here, 45-year-old female having such kind of non-healing wound, amputate like this, more than 2 rays were taken out, and this is not a way of treating or doing the amputation and dealing with the non-plantigrade foot. So in the pre-operative planning, there will be the adequate soft tissue to cover. There should be the adequate soft tissue to cover like this. Uh, uh, it was a non-healing ulcer. It was treated like this, and it was the infection was not healed, proximally migrated, bad soft tissue cover. So this procedure should not be done. In the pre-operative planning, it is very important to get a good soft tissue coverage, like as you can see in this example. So toe and the partial foot amputation you can do in the dry gangrene, but when you are doing the second toe amputation, you should be very very cautious about development of the hallux valgus deformity, because if you take out the second toe, majority of the time the first toe it migrates and may lead to the hallux valgus, provided if it is not stiff. And the transmetatarsal amputation, which is again a very good option for the diabetic foot patients, the gangrene, but the indication is gangrene must be limited to the toes and it should not be entered in the web space. Preserve the attachment of the dorsiflexor and the plantar flexors as we have discussed, and these are the amputation which are easily tolerable, and you can get a good orthosis and the patient can walk with the plantigrade foot. So these are the surgical incisions, and this is how the transmetatarsal amputation is done. And you have to maintain the parabola or cascade of the metatarsal, because if it is not maintained, you may get an abnormal pressure creating area and you may get a secondary ulcers on the amputation stump. So finally, it should be the plantigrade foot, braceable with the orthotics or the prosthetics. The other minor amputations, the limb preserving, they have a reduced anesthetic risk, it make you independent, but again they have a prolonged healing time, long hospitalization, maybe the risk of failure, and may require the further treatment. So here's a 55-year-old patient which I have discussed. It's a wet gangrene, active discharging sinus. He didn't want the amputation. He went to many surgeons, but during his opinions, he developed a fulminant necrosis, and he landed with the septic shock and finally amputated. So major amputation, no more surgery, they heals early, but the major risk bring the patient to the higher rehabilitation and independent threaten. Again, it's the last slide. Post revascularization failure is again a big problem. So this was a patient which was shared by Dr. Rahul Upadhyay from Jaipur. So this patient, he had some non-healing ulcer over the distal leg. He went, again, he didn't want the amputation. He went to multiple places. One vascular surgeon has advised that your limb can be saved. And he did some vascular procedure, as you can see the scar on the proximal thigh. But on the second day, he went to do the septic shock and he was amputated. But in the post revascularization failure, you can see that even the amputated limb, it is getting dark. So in the post revascularization failure, probably you require the higher level of the amputation and the risk of mortality is too high. So it should not be too difficult to determine the break point at which the effectiveness of the treatment is cost effective and even the cost saving. Many amputations, major amputations should be considered as an option for every patient with a diabetic foot. This is my concern. Thank you.
Thank you, Girish. That was a really interesting one. So friends, after these 6 very informative talks, I hope you have some idea about diabetic foot and how you're going to manage it. I hope these people have managed to clear a lot of doubts in your minds. We now move on to some interesting case presentations, which will actually make it easier for us to understand what the problem is and how to manage. Our first case is by Dr. Agashe. Dr. Agashe? Dr. Agashe, you need to unmute. Dr. Agashe.
Yeah.
Yeah. Agashe.
Sorry, can you see me now?
Yeah. Yes, yes. We can hear you.
Yeah. It's a middle-aged person, diabetic for 8 years, poorly controlled. He presented with pain and swelling of the left foot, especially the second toe and forefoot and midfoot. He had difficulty in walking for about 10 days, and he was a chronic barefoot walker. In spite of repeated instructions, he used to walk barefooted. You can see there is an incision on the plantar aspect as well. He has repeated episodes of infection on the plantar aspect for 1 year. Initially, he was treated with antibiotics for 6 weeks, operated twice 9 months ago somewhere else, and 6 months ago, I had done surgery. The MRI 6 months ago showed myositis on the plantar aspect of the foot with cortical erosion suggestive of osteomyelitis of second metatarsal. And that's the photograph taken about 5 months ago where he had delayed wound healing. That's the incision I had taken for removal of myositis and scraping. It was just a cortical erosion of second metatarsal. This was done 6 months prior to he presented to me in 2018. It took about a month to heal, but it finally healed, and it was well healed at the time of second presentation, which I am discussing now. So this is how he presented. That's the X-ray at presentation second time. You can see the second metatarsal. There is a periosteal reaction, destruction of second metatarsal, the disappearance of joint as well as osteomyelitis of the proximal phalanx. That's the MRI. You can see the second metatarsal. There is an osteomyelitic, there is a septic arthritis, and large soft tissue collections. And the MRI, which was compared to the earlier MRI, is reported as osteomyelitis with septic arthritis with soft tissue collections. Abscesses involving the second ray is a new finding. So previous MRI did not have abscesses, while this MRI had multiple abscesses in the foot, plantar as well as dorsal aspect, and osteomyelitis with destruction of second metatarsal as well as proximal phalanx. So this is where we are. We have a young middle-aged man with repeated infections on the plantar aspect. He is operated twice, last time by me. Delayed wound healing at surgery done 6 months ago. Recent episodes, symptomatic for 10 days. And the MRI shows a new finding of second metatarsal osteomyelitis with septic arthritis and soft tissue abscesses. Any options are we discussing?
Dr. Tushar Rege, I would first start with you. How would you approach this case, sir? Yeah, unmute.
This is the right time when I think I'll take the help of experts like y'all. As I said, it really happens, not avoiding the question, but I think this is where we really require expertise in bone management. But grossly, I would think I would again explore, try to have an adequate clearance if you are trying to save the second toe. And then with culture specific antibiotics, a prolonged course of antibiotics with adequate offloading over a long period of time.
So
That would be
which is the
basic approach.
commonest organism that you see in these foot infections, sir? And what is your antibiotic protocol? I mean, do you wait for the sampling or you start empirically, and how long you give IV and oral and all that?
As a rule, most of the infections are gram negative. Our first choice is now piperacillin tazobactam along with clindamycin. But when it comes to bone infections, we have found most organisms are susceptible to linezolid. The only problem with linezolid is poor tolerance, pancytopenia, and a lot of nausea. These are the only problems with linezolid. Otherwise, we have given linezolid for a prolonged time, 6 weeks to 8 weeks, definitely for sure in continuity.
And is oral as effective as intravenous?
Linezolid, yes, just the first or second day where it is IV, but otherwise a dose of 600 milligrams twice continuously. Our only problem is a large number of patients stop tolerating it over, after about 8 or 10 days. That becomes an issue.
Dr. Kurchadkar, how would you manage this? Unmute yourselves.
Am I okay?
Yeah. Yeah.
So I think this is like an ulcer with, though the patient doesn't have an ulcer, it's straight up an osteomyelitis. So here we need to be very, very aggressive with removing all the focus of infection. And you need to enter all these spaces. You need to do a compartment release, because here the abscesses could be traced into this compartment and everything has to come out. Saucerize the wounds, leave it open. And as I said, Dr. Rege said, start on the broad antibiotics. Another thing is, you have to think about anaerobes. So here, adding a metronidazole for a week or two is also recommended. The choice of antibiotic otherwise is the same as Dr. Rege said.
So would you take a dorsal or a plantar approach?
Well, here it's the plantar approach is recommended because most of the pathology looks like on the plantar side, and it's very difficult to go from dorsal. And we are not worried about the scar or anything like that, because here we may have to sometimes even excise the second metatarsal head if the infection is very severe.
Dr. Agashe, sir.
Yeah. He was operated twice, suffering for last 1 year with repeated infections. And I thought the proximal phalanx is also damaged. The toe was involved. And with these multiple abscesses, I thought we may not be able to get a real good infection control post debridement. However, on the MRI, I thought that these abscesses are quite well encapsulated. So I thought if I can excise the second ray as a whole, I may be able to achieve infection control. So that was my plan. That's the second row excision I have planned. That's a great toe, that's the second toe. And you can see this first toe, great toe is retracted with a tape. That's the plantar aspect. And I've taken an incision into the web space. Here there's a dissection between, that's the second, that's the third. And these are the abscesses. That's the abscess. So these encapsulated abscesses, I dissected on both sides without actually entering them. And that's the second toe, which I excised, intact abscesses. That's the absolutely clean area post-op, and that is I could close easily. That's the abscess I opened for collection of sample after I closed, so that I don't contaminate anything. Turned out to be Staph aureus with oxacillin susceptible. Just a word about this sensitivity report. If you notice, most of the labs, though they say this is methicillin sensitive Staphylococcus aureus, methicillin is never tested. It is either oxacillin, generally oxacillin, which is tested, and they report it as MSSA or MRSA. One important thing is to check for this cefoxitin screen. Cefoxitin screen so-called stimulates the dormant Staphylococcus or MRSA, and then they are picked up. So two things you have to check, not the methicillin, but cefoxitin screen. If it is